This conference will now be recorded.
All righty. Well, good evening, everyone. I've been gone for a little bit. I'm Gary, if you don't know me, and welcome to the AnCan Active Surveillance Group. This group is for people on active surveillance and not under any kind of treatment. If you are undergoing treatment or you have had treatment, we have groups that are better suited for you. Of course, you can stay and listen, but we can direct you to the other groups. Um, Again, welcome. And first, I'd like to thank the sponsors that make this possible, and that would be Bayer, Novartis, Johnson and Johnson, of course, their division Janssen, Myriad, Telix, Blue Earth Diagnostics, and Foundation Medicine. I just saw Dan out in Idaho join. Dan, do you need any time?
No, not tonight. Thank you, Gary.
Okay. You're looking quite rustic with the stash, I might add. Yeah, you got a different look there, bro. You got a different look.
Like
All
some
right.
villain. Gangster.
Yeah, you could be like the villain type, actually. All right. Well, we're going to, I'm going to ask Lou if he would like to listen or if he would like to tell us about his, where he's at in his journey with prostate cancer. Lou, are you there?
Coach Medved must really told those guys.
Okay. Don't know if that's Lou or not. Lou, is that you?
Man will be Willis, left side as you look in. Bounce.
Well, somebody's watching.
No, that's
basketball.
Roger was listening to a game.
Yeah, it sounds like a little basketball going on there. All right, Lou, are you out there? Okay, I tell you what, we'll figure that he's listening, and I will keep asking if he. Dan, do you know if he's? I don't see him on my screen.
He's on the screen. He's not muted.
Yeah, I'll check in with him. I'll text him.
I think, Dan, I suspect he's having problems with his microphone, and I've also put I've also pinned the number to call to the top of the chat window. And for those of you who don't know, I think most of you do. The chat window are the two little boxes at the top. And there's always a lot of stuff in there.
Yeah, we can hear you, Lou.
Okay, I figured it out.
Okay, well that's great. Welcome, hearty welcome to the group. And Dan gave us a little intro. Said that you might want to just listen tonight to see how this works, or perhaps you'd like to talk and tell us about your journey with the prostate cancer. And also I'd like to, if that's the case, we need to ask you a few questions so we can all kind of figure out where you're at and some input from all of us. So what would you like to do, sir?
I'll give you a quick minute, let you know where I'm at.
Well, it's going to take more than a quick minute because I'm going to ask you a bunch of questions. Hopefully you have some of the answers, such like, PSA, biopsies, what kind of biopsies, when it started. Have you got some of that stuff available?
So he doesn't have all of it.
I've been chasing this PSA thing for about 10 years, bouncing in between 4.5 to 7.5. And then my last checkup a couple months ago was 11.5, and they suggested maybe a biopsy. But then I asked for a retest, and then it was back to 6.6. So then they said, well, why don't you just keep an eye on it for the next 6 months? So I'm sort of Dan's been trying to walk me through when to get a biopsy. I had an MRI 2 years ago, and whatever scale is between 0 and 4, I came out as a 2, which the urologist didn't give me much of an answer. It's maybe you do have it, maybe you don't have it. So I'm sort of in the learning process of trying to figure it all out. Over.
All right. Well, let me just ask you a couple of quick questions. The PSA history. Do you go to the same lab? Do you go to the same place to get your blood drawn?
For the last 5 years, yes. The previous 5 years, I lived up in the Washington D.C. area.
All right, no problem there. Has anybody ever told you what to do and not to do before a PSA test?
Yeah, Dan just told me. So.
Okay, well,
So
you've
I
been
was
doing it-
taking,
you've been doing
I
it
was
for 5
taking
years, 10 years, and
supplements.
now you know.
Yeah.
Okay, all right, that's important. Okay, Dan, Lou, where are you located?
I am in Destin, Florida.
Okay, I'm over in Melbourne myself.
Okay.
Okay, Destin, Florida. And I guess you heard from AnCan from Dan? Correct?
Say that one more time, please.
You found out about, how did you hear about AnCan? You heard about it from Dan?
Yes, from Dan.
Okay, all right, good. How old are you?
67.
Okay. And by any chance, are you a veteran, sir?
Yes, sir.
Okay. By the way, to all the vets out there, a happy belated Veterans Day from me. So when you first started doing this PSA, I guess at 4.5, that's what year is that roughly when your urologist said you should get your PSA tested or whatever?
It was probably around 2014 or 15, somewhere in that vicinity.
Oh, wow.
Okay. All right. And where are you going to a community practice? Just you see a local urologist? Is that where you go?
Yeah, local urologist.
Okay. 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 So you've never had a biopsy, correct?
Correct.
Okay. To biopsy or not to biopsy? That is the question. All right.
Yeah.
Okay. Okay. Well, I'm going to turn it over to you. What do you think?
Well, so you said it's, so
Can I
you've,
interject real
you've been
quick?
watching it. Go ahead, Dan.
Interject. Yeah, so Lou and I talked a few days ago, and he told me everything where he was. And my recommendation to him, just to cut to the chase, was before he has a biopsy, he needs to ask for another MRI,
Bingo.
and then based on the outcome of that MRI, then maybe a biopsy if there are lesions, etc. And if his PSA is still high, then maybe they can talk about a biopsy. We did talk about PSA density and the size of his prostate, and he told me that his urologist said he couldn't tell the size of his prostate without a biopsy. I told him that was crap.
Yep.
That he could do the same with an MRI, and I told him he needed to find another urologist. So that was kind of where we left, and I recommended he come here and then listen to what we all have to say.
It sounds
Okay.
like good advice from your friend.
Yep. It certainly does.
So
For sure, another MRI before some type of invasive biopsy to find out if, in fact, sounds like the other guy told him it was a PIRADS 2, which means did they see something? I mean, he actually told them it could be, it couldn't be. Well, you need to get
Yeah,
it
they said there was a rough spot. Not sure if it was a lesion, but they said there was a rough spot on one part of the prostate. But Dan sort of told me that maybe that MRI didn't see the whole prostate, maybe only one side. So I don't know.
Well, it could have been a 2. It might have been a 2. Do you know if it was a 2 or 3 Tesla MRI?
I went to Pensacola. Supposedly they have one of the newer machines up there. Supposedly, is why they sent me 80 miles up there to where Dan is.
Okay, well, it
Lou-
might have been a 3T, but then again, for some reason, you might have moved, you might have had gas. There could have been something in your colon. Maybe the definition wasn't as good as that should have been, and it was something that they didn't bother telling you that hey, look, we really didn't get the pictures that we wanted. Perhaps they could have suggested we should do it again. But as what you said, I think that the thing to do before you think about, especially with it dropping back to 6.6, myself, I've had my PSA go from 6 to 12, double. I've been on active surveillance for almost 15 years. And nobody can explain, to the best of my knowledge, why some guys have the up and down and roller coaster PSA. Whether you had prostatitis when it was 11.5 and you had no symptoms, you were not symptomatic, you might have had some kind of inflammation going on. Everybody is different. So you're not going to get a definitive answer. But I think
Yeah, Gary, I had a cystoscopy about 3 years ago, and since then, it left me sort of burning, urinating, and I was on antibiotics for 6 months, then off for 3 months, then back on for another 4 months, and then they finally took me off all those antibiotics because I don't think it was really getting any better, but it just seems like things got a little worse after that cystoscopy. I don't know if that had anything to do with it, or they suspected maybe a prostate infection, so I don't know.
Yeah, perhaps, like I say, perhaps you had a touch of prostatitis, but Dan's last comment that he made, I believe, was like, go find someone else. And that's what I think a lot of the men on the screen will agree, that a new set of eyes on something is the way to go. And you have to find the right set of eyes. And that's where we can come in and maybe get you to somebody that we think will do better for you. I think Phil had his hand up, and you've got something?
Yeah. So Lou, I've been on active surveillance, I guess, for about 5 years, and the guys have heard me say that the trend is your friend, and I proved that again going to my doctor this week. So let's talk. It sounds like you've got a lot of years of PSAs. So you said they started out in 2014 at 4.5. Have you been getting what, an annual PSA?
Every 6 months. Well, it was annual. It was probably annual for the first 5 years or 6, and then about the last 4 years, it's been every 6 months.
And so, what has it been doing? Has it been going up, or has it been going up and down?
It's been basically going up from 4.5. It seems to. It's gone to 7.7, back to 6.6. You know, so the last couple of years, it seems like it's bouncing a little more.
But so it was. Is it accurate to say it was bouncing between 6 and 8 when they finally said, let's do an MRI?
Yeah, that's about accurate. It was bouncing probably between the high 5s to the high 6s.
All right. And then he says, get an MRI, and the MRI says PIRADS 2, and he didn't ask for a biopsy at that time.
Correct. He said he was trying to hold me off as long as possible for, some of the risk factors.
I'm going to give a shout out to your doctor, despite our other criticisms. A lot of other doctors would have already done a biopsy. So even though if he's not moving for another MRI before your next biopsy, that's I wouldn't say that's a good move, but other guys would have been biopsied already. So, the thing bouncing back and forth, certainly I can see that somebody would get a second MRI, take a look at that second MRI. It's real important that they compare the one MRI to the previous MRI. That's why it's always good to get an MRI, because you get a base case. That second MRI now comes out and doesn't say any change. I can see that your doc would say, okay, maybe get a biopsy, maybe not get a biopsy. Certainly a second opinion at any time is always welcome. So does that help you out, Lou, or confuse things?
No, it weighs heavy on your mind, right? You guys know it better than me because you're further down the road. But, it does weigh on your mind just waiting around every 6 months or 6 months.
Yeah, I get a PSA every 3 months. And what did you say? You're 67. I'm exactly your same age. So if your doc back in 2014 said you have a high PSA, he might have said, well, you're pretty young to have that. And what they mean is you're gonna need to watch things for a long time. Is that so bad? To watch your health? My doctor told me this week, he said, you're on the young side, which means that you're going to have to do this a long time. And he also said those guys that have been diagnosed with prostate cancer and on active surveillance outpace the general public by a long shot because we take care of ourselves. So I thought that was a good thing. I'll take that.
Yeah, and of course, we always sometimes what we do here, Lou, is we talk about anxiety, which you happen to mention, which is a big factor and something that most doctors don't take into account. The very first time when he says, "Oh, your PSA is high, you need to go get a PSA test," and then they start to talk. Mine went over 4. The urologist sent me to my primary care, sent me to the urologist, and right away he wanted to play with his robot. Well, 15 years later, nobody's playing with a robot. I've like I say, I've been on AS. So anxiety does play into it, and it does have a bearing on your mental state. In other words, if it weighs heavy on your mind and you need more answers, then you have to be your best advocate and move as quickly as you can to satisfy, so that you feel well mentally and physically. I think everybody's, as Dan said, and I think a second MRI is certainly the way to go to see if they see some actual lesions. And then you hang with us every week, and we'll send you, if we'll find somebody that we have faith in. Might be a little bit of a travel, but then again, it's all about your health, and you really don't want to do anything unless you have to, because as you said, the consequences of, going into some kind of treatment can be severe, the side effects. All right.
Yeah, my next appointment, Gary, is until May, so I don't know. I'm a little reluctant to wait till next May.
When did you have the MRI?
2 years ago, and about 2.5, almost 2.5 years now.
Yeah.
I could see having another MRI.
Yeah, I wouldn't want to wait till May, because I can tell that, you're a little antsy about this, and rightfully so. There isn't anybody on this screen that isn't antsy, because they know that the next time they go see the doc, something could be different. All right, Steve.
When I saw him in March, Gary, when I saw him in March, my previous 6-month visit, I asked about another MRI, and he said, no, it's not going to tell us anything different.
No.
So
that's concerning. That comment is very concerning.
Yeah. I was going to say that's bullshit, but okay, we can call it concern.
Well, it may
recorded,
not.
so we're being recorded, so I'll call it concerned also. But that's absolutely not the case. It would be like saying taking your photograph 6 months from now, there's not going to be some features that are different. At 67, speaking for myself with a lot more years than you, my face, there'd be a difference, and I don't buy that. That sounds.
I'll just have less hair. That's all.
I don't like. Well, there you go. But there'll be a change. That's what I'm saying. We don't want to see a change. You don't want to see, and you'll feel a lot better if somebody takes an MRI on a 3T machine. You prep for the MRI accordingly, and they say, we really don't see anything. That's great news. A path for active surveillance, and you can discuss about. At that point, you can make a much better decision about a MRI. I mean, a biopsy. Steve in Oregon got his hand up. Go ahead, Steve. Steve, are you there?
He's muted.
Okay, Steve. All right, how about Dan? Dan's got his hand up.
Yeah, just real briefly. So a lot of the things that you guys are talking about, we discussed. I also mentioned if he's going to have a biopsy, then it should be transperineal. And I also talked to him about maybe going to Mayo Clinic, that wherever he goes needs to go to a center of excellence for his next, rather than sticking around to the community care, because community urologist is not. And I gave him some of my experience, which you guys are well aware of. So
Okay,
I will
excellent.
continue to engage with Lou. I mean, he and I have been friends for a while, so and I did not talk about men speaking freely, but as he's discussing, that may be something that he wants to join in on.
Okay, that sounds good. And did very good advice. And Steve in Oregon, you with us? Steve, you had your hand up.
You're on mute.
Is on mute. All right. Okay. Well, we'll get back to him. Okay. All right. Lou, is there any other questions you have? It sounds, Dan gave you some really great advice, and of course, some of that he gathered from this group. So I'm sure he's telling you that pretty good bunch of guys, and this kind of peer support, you can't, I hate to say it, but this kind of stuff is priceless because you can't buy it, because you've got people that are living it, going through it in different stages, telling you their experiences. And you're also falling back on the knowledge of all the people that have been there, done that, as to where to go, who supports AS and who doesn't. So,
Yeah.
Dan,
Gary, I think Phil wanted to get in.
No, I'm
Phil
fine.
was. Are you sure?
Yeah.
Okay, I didn't see his hand, but I apologize. Dan's got his hand up, and maybe Bill's got his hand up.
You're on mute, Dan.
Dan.
You're on mute, Dan.
Okay, I just wanted to run through a couple of quick questions for Lou. Lou, are you on any medications?
I am. I'm on Losartan, which is for blood pressure, and Resistatin for cholesterol, I think it is.
Rosuvastatin?
That's the one.
Yeah. And is your weight been pretty steady through this last 10 years?
My wife passed away about 16 months ago, so I lost about 70 pounds.
Okay, well, that's good, because one of the things that maybe is not generally known is that being overweight actually falsely lowers your PSA and can give you a false sense of security. So that's good. If you're losing weight and your PSA is staying in a reasonable range, it's a little high. The other thing is, do you have the results of your MRI scan, the written results from the report?
Actually, while we were talking, I was just digging through some old records to try and see if I could find it.
Okay, because if this is a reasonable MRI facility and the radiologist is experienced, one of the very first things that they would say in the report is your prostate is X number of mLs, 30 mLs, 40 mLs, 60 mLs, 80 mLs. That's the volume that your urologist told you he couldn't tell, but it's in your MRI report. And with the volume and your PSA, you can calculate something called the PSA density, which is a better predictor than just looking at the PSA of what the data mean regarding your risk of prostate cancer. So you can look that up online, or we could tell you we can calculate it for you. But if you find your report, it should say right in the first sentence or two, what the volume of your prostate is.
Okay, Dan, that's all good information. Yeah, and if you can find, you're right. If you can find that point, they should have the volume for sure.
Okay, and we briefly talked about those things last week.
Okay.
Yeah.
Bill,
by the way,
did you
just as I mentioned a little earlier, we spend so much time talking about PSA, and we assume that everybody knows what makes it go up and down, but it's maybe everybody doesn't. One thing I will say, I think everybody knows that ejaculation will make your PSA go up. I don't think people realize that the half-life of PSA in your blood is about 5 days. So, I know a lot of guys think, well, if I just don't do anything for a day or two, it's okay. But it's probably not. It probably takes longer than that for the PSA to clear out of your system. Another one would be, Lou, do you do any bike riding?
I do not, just treadmill. I go to the gym
Okay.
3 days a week.
Okay, good for you. Yeah, as Gary said and Hugh said, we hopefully a lot of us take this as a wake up, and we kind of get a little religious about taking care of ourselves. But anyway, good luck to you, and if we can help, let us know.
Thank you, gentlemen. I appreciate it.
Okay, Steve, in Oregon, you got something for Lou?
Yeah, I was going to say something earlier, but the organizer had me cut off here at the mic, so I had to switch over to the phone. Some glitch in the electronics. But Hugh, there's a wonderful source. It's called Up to Date, and what it is, you pay $20 for 7 days or $60 for 30 days, whatever. But you get the most recent research on a topic. And there's one about our level of cancer put out by Williams and Punan, and the gentleman that Jim wants to talk about, Cooper, whatever his name is, out of UCSF. On
Not Cooper.
yes, exactly. Those three guys put out a paper that you can pay very little, $20 for 7 days, and you get a copy of that for that particular research. But the angst that you feel is genuine, and it's universal. And I don't think it needs to be so because of AnCan in particular, but these other resources that we have in recent research that, in essence, maybe our treating physician has no idea about. I tripped across Up to Date only because of this particular article that was just recently printed and available. I'll get off the podium here, but I feel I'm you a few years ago, and the advice is wonderful. You know, the problem becomes being able to be assertive, to walk around with a pair of balls. And the doctor can say whatever he wants to say because he walks out of that office. He doesn't have to worry about prostate cancer, except how much money he's going to bring into his coffer. So I don't know what the tools are that the group as a whole would suggest, but I would find a really good professional friend in the medical field, or even a psychologist, or even a priest, or whatever, and begin to work through this angst, because it was most crippling for me, and I hear it universally when I go to PCRI or anywhere else. It just cripples us for far too many years, which means that this kind of open dialogue is wonderful for avoiding paying so much to a psychiatrist. But I wonder sometimes, we sit here talking and we divulge ourselves. It's taped and it's put out there for everyone to see. Wonderful. On the other hand, there are elements that we don't want them to hear this. And let me just take a moment more of your time. I'd like the group to talk about the issue at some point where the doctor is more leaning towards watchful waiting because of our age. NCCN guidelines say that your last 5 years, 5 to 10 years, but certainly 5 years, you shouldn't be on active surveillance. You should be maybe considering watchful waiting. And the whole premise of what the group is doing for each of us is to arm us so we make the right choice for ourselves and we remain on active surveillance. Thanks for allowing me a moment. I'm off.
Okay. All right, Lou, is there anything else that we can do for you?
I did just find my results. I don't know if you want to hear them from the
MRI?
Yeah.
Yeah.
Did you find any volume?
Yes, it says the prostate volume corresponding to 62 milliliters,
Yeah.
I guess.
Okay.
Left peripheral zone has a single focus of low density T2 measuring 6 millimeters without any abnormal diffusion, consistent with a PA RADS 3 finding, intermediate. Is this making sense to you guys?
Yep.
Yeah, they're saying.
Yeah, it's making sense. But if there's a target, if there's something there, I mean, you know, that's what they're supposed to go in and biopsy.
Yeah, I think the best thing circles around to getting another MRI from another from a center of excellence, and maybe getting another set of eyes on because you don't want to. I mean, if it's a PIRADS 3, I think that's what you said it was. That scale goes from 1 to 5, correct? So 3, they might have saw something, but did they mention any kind of lesion?
It's a T2. I heard you guys mention T2 and T3. Is there a difference?
Yes.
Well, T3 is the strength of the magnet. That's a 3 Tesla magnet. But hypo, when they said there's a hypodensity, that's what prostate cancer shows up as. It shows up as a black spot on a white scan, and that's the target they're supposed to go after now.
Well, I think that, talking about anxiousness, and let's not get Lou over crazy here. I think the first advice to seek out a center of excellence. He can talk to Dan about it. Maybe go up to Mayo. That's where I go also, up in Jacksonville, and get a second look and a clean set of eyes on it. I think that would be the best advice at this particular point. The size of the prostate doesn't seem, for a 67-year-old male, I don't think is something to be overly concerned with. 62.
Gary, it says post-contrast and demonstrates no abnormal enhancing nodules with a heterogeneous gland. The semi-vesicles are normal, no abnormal lymph nodes in the pelvis.
Very good. That's all good news. Ray in Santa Monica, did you have your hand up?
Yeah, I mean, I was just going to ask.
Muted.
You're muted, Ray. Can't hear you.
At a 2T machine that he was, or a 3T machine? Looks like a 2T.
Sounds like it was a 2T, so that's another thing they've got to start out, because they'll get a much better definition on a 3T machine.
Yeah. And the other question was, I don't know if he said this, is any history of prostate cancer in his family?
No, there's not.
Okay. I mean, everyone said I think I'd just get it on a 3T and go from there at a center of excellence.
Harry, you had your hand up?
Yeah, our family's been through some cancer with my wife too. And one of the things we did and I don't know if it was purposeful, but to alleviate some of the stress, and again, this wasn't planned, is to take the right action in areas that we can help ourselves. For example, sleep, exercise, and eating right. It may not be, and everybody's got their own plan on that, or maybe we could get somebody to come in, but that helped me tremendously. And I know when I was helping out my wife, that's what you did. You get the medical, I guess it's eat, sleep, exercise, and make sure you're getting the right medical, and do something fun. I mean, those are what I follow to try to stay in the positive.
Yeah, Gary, my sleep's terrible. I mean, well, especially since my wife passed, it's extremely terrible. But
my wife passed too, and yeah, I hear you.
I get 2 hours of sleep, and then I get up and pee and sit up for half an hour, and then go back down for another couple hours. So it's bouncing around like that.
I saw somebody for sleep, and if I got a problem, I'm going to take care of it. Like that's the way that's the way my wife lived, and I learned a lot from that.
And they gave me sleeping pills, and I got a ton of them, but I'll tell you, I feel worse in the morning after.
Don't do it. Don't do it.
Yeah, Dan, did you have your hand up? You want to say something?
Yeah, a couple of things. First of all, I mean, we've got other people in Florida. Instead of sending Lou off in search of a good MRI machine and a better doctor, can't we give him some more specific advice on who to see and where and when?
Yeah, we talked, Dan, just so they know, we talked about trying to get him to Mayo Clinic at Jacksonville, because that's where I go and that's where Gary goes. So
yeah, I mean, that
next week.
That sounds good. And the other thing is, I just want to tell Lou that I calculated his PSA density, and it's 0.106, which is good. Anything below 0.15 is considered less of a risk for prostate cancer. So good for you. Of course, that's now 2 years old now, but it's still good.
Can you repeat that number for me, please?
0.106.
And you say that's decent or good?
Yeah.
Anything below 0.15 is considered to be low risk for prostate cancer.
Dan, you calculated that on his latest at a 6.6, or did you do
Yes.
that on the?
Yes, I use 6.6 and 62.
Okay.
And so that's 0.06?
Point 106.
Yeah.
Thank you. I appreciate it.
Okay.
No problem.
I think we got another hand up, Gary. Rick had his hand up.
Rick's got his hand up. Go ahead, Rick.
Yeah, I know we've said this before and we'll keep saying it again, but we don't use the term watchful waiting in this forum anytime, unless you're a very elderly man. If you're watching your PSA, either before you got diagnosed or after you've been diagnosed and you haven't had treatment, then it is an active pastime. There's a lot of things you got to do. This is what Gary and Hugh and the rest of the guys are all saying. We don't just allow it to happen. So let's try not to use watchful waiting. We need to pick up anytime we do and get active, because if you're not active, the disease can get away from you.
Okay. Thank you, Rick.
And sometimes relentlessly active.
You got it.
And you always have to be your own best advocate. You have to keep asking questions. You have to understand. And this is one of the best forums that you're going to find to answer questions, get answers, or we can compile questions for you to ask the urologist. Just stick with us. Is there anything else we can do for you, Lou?
Knowledge alleviates stress.
Exactly.
Lou, you're on mute.
Yeah, it really helps talking to you guys. I really appreciate the advice.
Well,
Okay,
come
no
back and
problem.
see us.
Hey, can we
Gary,
put
let's
that,
see if we can catch some other guys.
Yep, here we go. Michael D.
Yes, sir.
All righty, you
The
need a
reason
little
I'm
time
here-
or something?
Well, yes. The reason I'm here is I have gotten a little bit organized for the first time in this whole process. I finally made a chronological calendar here of what all has been going on the last 2 or 3 years, and it's interesting to sit and look at right now. Actually, I hear all you other guys spitting out all this information by date, and I don't know what's happened to me, so I decided to put it all together. Now, I've already decided that my local group in Nashville is a little casual. First of all, they sent me to different labs for different types of testing, which I didn't care for because that doesn't mean a whole lot because I've seen the variation in labs. And then I get a little downward tick in my PSA, and the guy says, "You look great. See you in 6 months." I don't like that.
What kind of downward tick are we talking? From where to where?
Well, I've got an average of over 3 or 4 years here. It's 5, but it's gone from let's see, it's gone from 3.48 to 6.6, and it's fluctuated all in between there for the last 3 or 4 years.
That's fine.
Okay, but you're
So-
sitting at a 5 average for 5 years. That's how old are you, Michael?
76.
Dude, you're sitting in a pretty good place. What else is going on?
Well, I need a group of excellence.
Michael, are you new?
Well, I've been around you guys. You just didn't know it. I wound up in another group, and Rick ran me out. And it's good to see him again, by the way, in the right group.
Okay.
But anyway, I've
You're
been
new
on,
to this. You're new to this group.
I'm new to this group actively. I've been
Okay.
watching you guys for a couple of 3 times.
All right.
I got a lot to share, I guess, but I don't know what is the best thing to do. I'm about to approach the second opinion platform here. Rick has helped me a lot with this. Dr. Epstein in New York, I'm going to contact him with the proper instructions here and the proper procedures, and not step on anybody's toes, and ask if he will do a second opinion on my 2 biopsies. There's a couple of kickers in my history here, though, that are kind of interesting. I've had a lot done, but it's kind of out of order and stuff. I've only had 1 MRI way back early. It was with contrast and all that. It seems like it was done well, but it came up totally negative of any pathology.
Okay.
And so we went ahead, I guess, and did because of PSA and some other things, went ahead and did the first biopsy a few months after that MRI. We haven't done an MRI since. Okay. The only thing I got out of that MRI was a 22 cc volume prostate. The rest of it was okay, normal, nothing.
So, Michael, when did you have the MRI? Before the first biopsy?
Yes, in 2022.
What did the biopsy show?
Nothing.
They showed nothing. Okay.
It came back negative?
MRI, it said showed nothing.
Yeah.
Local and then you had a second biopsy.
Well, my numbers kept not jiving with nothing. You know what I mean? My PSA and all that. And I guess it got some concern, and they decided to go ahead and do the first biopsy. Now, the first biopsy.
Michael, what was the highest PSA you ever had? 6.6?
6.6.
That's the highest ever.
Ever.
That's not a whole lot for a 76-year-old.
No.
Thank
then
you.
He went and he did a biopsy without doing an MRI. We did the MRI first, and then he did the biopsy.
The biopsy came back negative?
No, the biopsy came back almost negative. It came back with 2 cores, slightly positive, 5 and 10% out of 15. And of course, the Gleason was 6 and a grade 1.
Okay.
So anyway, that's another concern of mine too. The second biopsy, which was a year later, after continued fluctuation of PSA and whatever, and some other tests, came back totally different as far as core samples and core percentages and number of cores and whatever. Now I'm sure it was at least slightly targeted, because they surely must have based a little bit of it on the quadrants or the areas that were found with the first biopsy. And there was 1 area found, so I'm sure they went there first and then around it second or whatever. So the second biopsy had to be a little bit of a targeted biopsy. It came back.
Michael, is the same people doing this? Or
No, sir. That's my. No, it was 2 different
labs. How did the first person know where to go for the second biopsy? I'm not.
I have
I'm
no
not
idea.
You at all.
I don't know.
Well, I don't think it was targeted at all. I think you're wrong in that statement. If you don't have the same person working on you the second time that poked you the first time, how would he know where to poke you? The second guy's going to know where to poke. How's he going to know?
Same urologist, different labs.
But Michael, it sounds like you're concerned, like, because the biopsy results are coming up with more cores the second time, that, you're concerned that your cancer is growing. It's not necessarily. It's not what it's saying.
Grade 1.
So you still 3.36. Okay, 3 plus 3 is 6. So
how many cores? How many cores were discovered on the second biopsy?
5 positive.
Okay.
3 greater than 50%.
They probably targeted at least the area that they had it before. So if you're getting it, if you're getting in the same area, they're testing almost the same spot.
I'm sure, even though it's different facilities, there's some information must have been shared through my urologist as to where to go.
Right. So I wouldn't be concerned so much of the additional cores. We expect additional cores the second time around. Being positive.
Great. That makes me feel a bit better.
Well, the second opinion.
I do think I would like a second opinion, though. Sorry.
Go ahead.
I do think I would like to pursue a second opinion, and Rick agreed with me, and I'm going to contact Dr. Epstein, and is it Epstein or Epstein?
Epstein.
Stein.
Epstein.
Epstein.
I've got a couple of questions about how to do this properly and not offend anyone, but I was going to shoot him an email first and just ask him if he would be interested in doing a second opinion, then go back to my urologist and tell him that I have found a source for a second opinion. I know how to get my slides. I know where they are. They're in 2 different locations. Okay. And does it matter if they're a year apart and one is a little bit older than the other, as far as a second opinion oncologist would look at? I mean, does the age matter? It's preserved in the slide, I know, but
why do you want both
I
of them?
don't think it does.
It can be up to 10 years old, but I believe Dr. Epstein will want the latest slides. He wants to
the
know
latest
what's going
slide.
on
Okay.
now. He would not
That's
want to
one
know what's
question.
going on 2 years ago and who did it. He wants
Okay.
to know what's happening now. So, and
Now,
there,
that was
go ahead.
about 1 year ago. Not quite.
Well, you're good,
So-
because like I say, they last up to 10 years or more. So you're good.
Michael,
He-
what's your
Go ahead,
concern?
Well,
My concern
I was
is-
going to say that on one thing on the targeting you were talking about. So when they did your biopsies, they pull those each from one of 12 different areas, basically. So they would kind of know where to go back and target and look generally. If they just looked at your old biopsy and they said, here, a needle was put in this quadrant, then they might know to go back and look there. In my personal case, they found Gleason 3+4 small percentage in an area where there was no lesion. And then a separate doctor and a separate facility a year later back and replicated that. And he found the same amount of Gleason 3+4. No lesion to target. He just went into that same area and found it again. So you wouldn't call it targeted, I don't guess, but he knows by looking at your old biopsy report, kind of the general area. And I'm gonna make a comment about this second opinion. If it insults somebody for you to ask for a second opinion, then they don't have faith in themselves. I'm sorry, that's just the way I feel. And I did recently get a second opinion from New York, from Dr. Epstein, and he's very helpful there in getting that done. And in my case, he was able to request and get those. He's got a form on his website that he asked that your doctor fill out, and mine, they didn't want to fill it out. They said, if he was going to do it, he should request. I told him that. He requested and it got done.
There's a place for a patient to fill that out too, I believe. The patient fill it out in addition to the doctor.
You're correct. It is both of you.
Well, what would you do if you were me?
You have a second opinion.
I would
get a second
I'd ask
opinion
Dr.
without a
Epstein.
doubt.
Yeah, I'd ask Dr. Epstein to get me the second opinion. He does it fairly quickly. He's very polite. If your insurance wouldn't pay for it, it's not a whole lot out of pocket. We hear from $300 to $400, I guess. That's a small investment for my peace of mind.
On the
in
initial
my case,
contact, I'm sorry.
But
My
in my
initial
case,
contact
Medicare
with
paid
him.
for it.
I need to keep it simple and brief and not go into a whole lot of detail, I guess. He'll figure all that out.
Correct. He
So
knows
if-
what
so if
he's done it tens of thousands of times. So he knows what he's doing. It's kind of a painless procedure. You don't, as Michael says, it's not a really, he can make it happen. You can make it happen. Any doctor, any urologist, any pathologist should never have a qualm about a patient wanting a second opinion. In fact, most of them should. Go ahead.
I should inform my urologist, I presume.
Yeah, you can tell him you're getting a second opinion from Dr. Epstein. Hopefully he knows who the hell he is.
Yeah, really.
Yeah, really.
If you
get pushback, you've got to wonder how qualified your doctor is. I got pushback and I just left.
Well, I tell you, when the PSA went down about a half a point, no, 3/4 of a point, I'll see you in 6 months. That just really wasn't good enough because I'm doing PSAs back and forth between my urologist and my primary care person on my own, roughly every 3 months.
Are they different labs?
They are.
Yeah,
One's
don't do that.
Well, I'm
Fair enough.
monitoring each one continuously. You know, I know what Quest is doing. I know what LabCorp is doing.
All right,
They're
but
not that
Michael,
far
in
apart.
general, you being a 76-year-old male with an average PSA of 5, and you've got a 3 + 3 6, you're in a fairly good space, I would think, to the consensus of this group. So I think if you go out and you get yourself your second opinion from Epstein, let him look at it, stick with us, come back and tell us what's going on, and take it from there. You'll be in good hands.
Thank you, sir. You know, the bottom line for me, though, is I don't know of too many cases of cancer that went away.
Well, let's jump into that one, Mike.
Yeah.
Michael, because a 3 + 3 Gleason 6. We've had the experts in active surveillance on and talking about this, and what they've said now is Gleason 6 never metastasizes, ever.
Really?
Yes.
You can live with it.
Okay.
Yeah, put my hand
That's
up.
the purpose
15
of
years,
active
15
surveillance.
years so far.
Well, I've been in it 3 years now, so.
It doesn't mean that you're out of the woods or anything. You have to stay active in that. You have to keep watching it. But a 6 on its own, you've got time. Okay.
You want it, yeah.
True 6.
Don't think that you got to jump at anything.
Hey, you wanted to say something to Michael?
Yeah, I mean, I talked to an ER doctor, 70 years of age, going in to have his prostate taken out down at MD Anderson, and they found 4, and he was a 6. So I mean, it's a crapshoot, and
it's not a crapshoot.
Hey,
it's not a crapshoot. It is not a crapshoot.
You can't assure
when
yourself
when you're a Gleason, Steve, when you're
without
a
better
true
testing,
Gleason 6,
hold up,
Gleason 6 will not metastasize.
Hold up now.
If you have a true 6, that's true. Everyone's heard that in lectures. You're going to hang your hat on 1/10 of 1% of your prostate in a biopsy? Jesus.
That's why you're doing an MRI.
On the other hand, are you suggesting you have it poked 10,000 times in its entirety? Is that another option? We can
Essentially a removal.
We can only do what we can do. The question of multiple biopsies is one of the big areas that we discuss, and that's been researched, and everybody talks about it. So you have pathology clinically by somebody like Dr. Epstein. The guy tells you got a 3 + 3 6 Gleason. You're going to go look for more, or you're going to take what can you do? 6 + 6 is where you want to be. That's if you've got to have a number, that's the one you want.
So we're not suggesting that you get a Gleason 6 report, you don't have to do anything. What we're suggesting is that you have to stay on active surveillance.
Correct.
So in my case, I've got a Gleason 6, I've got a Gleason 7. My PSA stays steady, my MRI stays steady. My doctor is sitting there saying, we're not going to do anything. Okay, I'm not going to get any more biopsies. If all of a sudden my PSA goes to 15 or 20 and the MRI comes back and says, whoa, you've had something really big grow here, then we're going to go for a biopsy, and then we're going to adjust and say treatment or whatever. I'm not suggesting that you're out of the woods. What I'm suggesting,
not at all,
that you have time to keep evaluating these things.
I think Dr. Epstein may suggest a little bit of further testing, don't you? Maybe a newer MRI or something like that to start with.
Well,
number one,
but if you're on active surveillance, you're going to get an MRI.
But keep in mind, Jonathan Epstein is a pathologist. He's going to give you a second opinion on your pathology. He might give you he might give his opinion on the MRIs and everything else. But you're not seeking a second opinion from him on anything but the pathology.
Okay.
And he's an expert in it.
You're right.
And I would send
And
them
if you
both
get
of
it,
your,
if you
I would send them both of your
get
sets
another
of slides
MRI
just to be on the safe side.
You would? Okay. Now, I can
if you
get those,
another
but
MRI,
did I know where to get those? Who to contact, telephone numbers, companies, the whole business. Do I do that or what? Do I get these slides in my hands?
Michael? In regards
to get
to what?
the slides.
You contact Dr. Epstein, and I want you to look at your pathology report. Definitely your most recent one. It probably has some numbers at the top that specifically identify it. And you want to, of course, give Dr. Epstein your name, your date of birth, your hospital, and then on that report, it's probably going to have some identifying numbers. You want to give those to him so that he has as much information as he can to seek out your correct slides. And probably nothing wrong with having him look at two and give him that one. But I would be sure at the top that I was giving him my most recent hospital, my most recent biopsy information, and then if you want to do the second one, then give him that one too. And in my case, he handled it from there because my doctor didn't want to do the form.
Well, I got a feeling I know mine's personality too, and I got a feeling that's what I'm going to get.
But you're not. You're urologist. If Dr. Epstein reads something different, he's not reading something different that your urologist did. He's reading something different that the pathology lab said.
Okay.
That your urologist sent that to, or your hospital. It's really it's really a big difference. I mean, you're not insulting your urologist. You're just not. That's the best way I can say.
Would you consider sticking with this group for now? This urology group?
Are they at a center of excellence?
No.
Okay.
It's a large group, but they're not. Vanderbilt is the only center of excellence, I think, in Nashville, maybe, or close to it.
Do we know who is it, and throw that name
Nashville
out?
Urology Nashville Urology Associates. There's probably 50 of them or more.
Sometimes Rick's got some familiarity. Who is your specific doctor?
Dr. Heath Hawkins.
Yeah, I think we talked about this, and I suggested you go to Vanderbilt, and I think I may even have suggested a couple of names at Vanderbilt. There's a lady there. I think I gave you a lady who I think is good. Sparada, I forget her last name. She's good. I've heard her speak. And also Penson is there. So those are the two. Penson is one. And then the other lady who's the other lady, I put her name in the chat window for you, is the other one who I would see at Vanderbilt.
I think we'll see what Epstein says, and go from there.
You got it. Hey, I just, Michael, I want to catch, Gary, let's catch Ray. He's got his hand up, and then Michael, we got to catch some other guys. We can come back, if that's okay.
Just real quick, LabCorp, first of all, has two different assays for PSA. They have the PSA2, which is, I think, Ecol, and then they have the Roche assay. So you want to make sure you have the same assay the whole time. Just to give you an example, about 4 months ago, I had both of them done. The Echo was 1.3 PSA, and the Roche was at 2.5. So they can differ considerably. The other thing you should consider doing too is getting a free PSA in addition to your regular PSA to look at that ratio, because that can give you a lot. And the last question I had was, did you ever have a genomics of your biopsy done, like a Decipher score, any of those?
I have, and I'm waiting on a copy from Myriad right now of the test that was done with them. I've also had an exosome test, I don't know if that's in that class of test or not, but I'm waiting on Myriad to send me a copy of their what's it called, Prolastic or something?
Polaris.
Polaris. Yeah.
Yeah.
Okay.
Come back next week with the results.
Will do.
Okay. All right,
Thank you,
Gary,
sir.
who do you got?
All right, Mark Mizarek, what can we do for you?
Good evening, gentlemen. I had two questions, one of which is more or less a report that I'll start with just because I learned of, Mike Crosby and Prostate ID through this group. I did submit my MRI to them, and the results came back slightly different than the 3T MRIs that I got from UCLA. They had my prostate at 42 cc's versus UCLA at 35. And as a result, the density dropped from 0.26 to 0.21. And they also reduced the PIRAD score from 5 to 4. I haven't had a chance to discuss this yet. Literally just got it back a couple of days ago with the doctors, but I wanted to let you know, all of you, that's what happened. And Mike Bing Crosby has been just phenomenal. He's called me back, given me plenty of time to explain things and walk me through it. I know there was some consternation a few months or a few weeks ago about that test and its newness. So I just thought I would share my experience with the group.
Great. Very good. Good to hear.
Oh, and by the way, it did not show anything other than the one lesion that I've been tracking for 7 years. So that was positive because treating the rest of the gland, if I do have to go through treatment in the near future, that would have been an important development to consider.
Absolutely.
So my other question for you gentlemen is, have any of you been diagnosed with intermediate stage cancer and opted to remain on active surveillance? And if so, would it be possible to just compare some of your metrics and scores versus what I'm dealing with?
When you say intermediate, 3+4?
Yeah, UCLA, there were 5 cores taken. UCLA had 3 of them at 3.4 and 2 of them at 4.3. When Epstein did the second reading, he had them all at 3.4. And he also reduced the percentage of 4s in each and every one of the cores. He gave an explanation to me for why, and he said the mucinous pattern that appears sometimes confuses the radiologists, and they look at it. I'm sorry, the pathologists, and they look at it and they think it's something else like the cribriform. And so he actually, with his experience, basically downgraded it. But he still said the percentages, which were like 40% or more in the core, in some of the cores, kept me in that borderline between staying on active surveillance and actively seeking treatment. So I have some scheduled appointments coming up with a couple of doctors this Friday and then in 2 weeks. But I was just curious to know if any of you guys have had similar, evaluations and opted to remain on active surveillance.
Mark, what kind of volumes did you get on the 4 with Dr. Epstein?
Hang on, I'll tell you in 1 sec. Yeah, forgive me. I was just out driving and I just got back, so I'm just pulling my notes here.
And I'd be curious to know, did Epstein suggest that you stay on active surveillance? Did you ask him?
Yeah, I did talk to him about it. He felt that that he would advise treatment because of the percentages being in that 40 to 50 or 60 range. But the ones from UCLA for the same cores were substantially higher. I mean, UCLA had them at like 70, 80, 90%. Had they been 5, 10%, 15%, then I guess it would have been a different story. But he felt at this point that some sort of treatment maybe
Let me just ask this to the group. You guys out there, that's 3+4s. Any of you guys got 4 in the 40% volume group? You got a 4. What is the 4, and what do you got?
Small.
Yeah.
10, 15%. And all I had was 1 core.
Right.
Mark, how many cores did the final of 3 4s?
There was 5 cores taken on a targeted biopsy, and initially UCLA had 3 of them at 3.4 and 2 of them at 4.3, and Dr. Epstein had them all at 3.4.
So 5 at 3.4 from Epstein, right?
Correct.
Okay.
In volumes of 40%?
30, 20, 40, 50, and 5. So 20, 30, 40,
Okay.
50, and 5.
Okay. All right.
Michael's got his hand up.
Okay, Michael.
So question, that was a targeted biopsy, and I think I guessed that you've got 3 positive cores. Did all those come from the same target? Because you only count 1 if they came from the same target.
Yes. They were all on the same target. 3 of whom were directly on the target using the micro ultrasound and transperineal guided biopsy, and 2 of them were by Dr. Brisbane. He wanted to do them around the peripheral of the suspicious lesion. So it was not random in the other side or any other aspect of any other area of the gland.
Okay. So I mean, your percentage does sound on the higher side, and that needs to be seriously considered. But I only think you really count 1 from what you're describing. That is 1 needle biopsy. When you target a lesion, regardless if you get 3 positives or 4 positives, it's really only 1 positive. You're just going after the same thing multiple times.
Right.
Which I just want to say that so you understand you don't have as many positive biopsies as you think you do.
Okay.
Mark,
So
are you in LA?
Yes.
So have you had any thought about seeing Dr. Scholes?
Dr. Scholes has been my primary doctor for 7 years on this. He recommended that I go to Dr. Albert Chang at UCLA for the 1-day high dose radiation brachytherapy. And I've had consultations with Chang so far, and I have another one scheduled for Friday of this week now that I got back other results like Ambry and Decipher. And by the way, the Ambry test came back completely negative, no mutations, no BRCA1, 2, or anything else. Right. And Decipher came back with a 0.5. So that, again, consistent with the intermediate risk type of assessment from the biopsies.
I would take under serious consideration, what Dr. Scholes says, because I think he's a very favorable person towards continuing on active surveillance. I don't know him personally, but I've listened to him speak in person and listened to him speak on a lot of videos. So, I would seriously consider his advice.
Yeah, he's got a long track history with UCLA. He told me they're getting ready to write up and publish hundreds of cases they've done together. And so he has a pretty good feel for this space.
Yeah, he'd definitely be a man to listen to, I would say.
Oh, no question about it. And as I mentioned, he is the one who suggested I talk to Dr. Chang, which I have done. And I'm going to swing back around and speak with Dr. Brisbane, who did the actual biopsy, who's a colleague of Dr. Chang's over at UCLA. But at this stage, I was just curious because, Gary, I hear you talking about 15 years on active surveillance, and I don't recall the specifics of your diagnosis and so forth. But I was just wondering because, there are so many instances, including case studies that Dr. Scholes has shared with all of us through the PCRI, where men who chose not to go through treatment remained on active surveillance in spite of having what would otherwise have been considered intermediate risk test results. And 10, 20 years later, they're still on active surveillance. And it's also
I've only been a 3+3 and no lesions.
Okay.
Okay. I've only had a 3+3 6 Gleason and no notable lesions. I've only had 2 biopsies.
Remember when you talk about intermediate, you do divide that into 2 separate categories too. Favorable intermediate and unfavorable intermediate. And if you look at your, I don't like guidelines because I'd say that's what they are. They're guidelines, but if you look at your guidelines, NCCN,
Maybe a piece of cheese. You
AUA,
bringing the cheese
different
back?
ones,
Mhm.
you know, what they say about unfavorable intermediate versus favorable, but then more importantly is your doctor, because I think you're under a pretty good one there. I really do.
Well,
Rick's got his hand up.
historic.
Rick, what do you want to say?
Well, you know, Mark and I spoke at PCRI, and Mark has been with Dr. Scholes for a very long time. I'm not sure that he was getting the best attention from Dr. Scholes. And actually, I convinced him that he should go to UCLA at least to get his biopsy, which he did. Whilst I think Dr. Scholes is very reputable, he's not necessarily the gold standard. And I would say that if the peeps at UCLA are asking him to consider treatment, there's probably good reason. I happen to trust Albert Chang. I've known him for many, many, many years. I think at this point, Mark is probably as educated as he can be on whether he wants to stay on 3+4 active surveillance or go for treatment. It's one of these situations. You know, this is another situation, maybe a bit like Greg Burns. And we had another gent who was in the low intermediate group on Monday night, same situation, that there comes a point where you could go one way, you could go the other. I mean, Hugh's still comfortably in active surveillance. He's not at the point where he thinks he might need to jump, but there comes a point when you just don't know. So I don't want to, I don't think we should be pushing Mark back to Dr. Scholes. He knows Dr. Scholes better than most people here do, including me.
Well, thank you, Rick. I appreciate that, all those comments, and your advice previously as well as tonight. Just to add some important information, on the phone, speaking with Dr. Epstein, I asked him the same questions, and he said he didn't feel the cancer was low grade and that it didn't warrant remaining on active surveillance. And that's after he was the one who kind of downgraded it, you know, from 4 3s to 3 4s. And he downgraded the percentage of 4s from what was 60 and 90, according to UCLA, down to 40 and 50, which, you know, it's still higher than we'd like to see, but it's a substantial reduction, you know, from one to the other. So keeping that in mind, you know, right now, Epstein, Scholes, and Chang are all recommending, you know, some treatment. And Chang, of course, being the one who would do the HDR brachytherapy, made it sound just like Scholes had said, which is it's a rather simple one-day procedure with low risk of side effects and you know, a great deal of history in his hands specifically. So you know, I'm seriously considering that. I was just curious to know whether any of you were in.
So Mark, have you would you do a genomic test on the higher grade stuff?
The Decipher test came back at 0.5, as I mentioned, and on the Ambry, which was, you know, for the regular, you know, saliva test for all the genes, there was nothing significantly found. No mutations whatsoever. No BRCA1s or 2s. So that leads me to think back to what I learned from Dr. Scholes and PCRI over all these years, which is, you know, if the cancer remains localized in the prostate, chances are, you know, it's not going to affect you for a long time. It's only if it metastasizes. And so if the risk of metastasis is fairly low or reasonably low, then that made me think, do I want to stay, you know, another 6 months or a year on active surveillance, or should I, you know, finally go in and get something done now that there has been, you know, this change?
How old are you,
Mark,
Mark?
AnCan has the low to intermediate, and it seems like, you know, at least you're probably looking like you could probably get better advice from that group than you can from this group.
I
You might
understand. I
find,
appreciate
you
that.
might find
And
somebody that parallels your situation. Like on this screen, there's a lot of people where their situation kind of parallels others. And it sounds like you must, I need to take that step up to perhaps get a better insight as to what those people have experienced and what their experience has been with whatever kind of treatment that your brachytherapy that you're speaking of. There might be somebody there that's done it. Of course, we don't want to talk treatment here, but you kind of open that can. So that might be a group better suited at this particular point in time.
So Mark, I mean,
absolutely, and
you're asking
plan
you're
on
asking
joining.
a crystal ball. You know, that's the crystal ball question. You'd have to know. It's almost impossible to know. You have to do what feels right for you. I think the guiding principle, as I understand it, is prostate cancer in the prostate is 100% curable. Prostate cancer outside the prostate is not curable. And that's what we all wrestle with. You know, you don't want to miss an opportunity. And, you know, it's a tough spot to be in. And, you know, I don't envy you, but nobody really knows the answer to the question you're asking.
Understood. I was just curious to know if any of you gentlemen had been in a similar set of circumstances and opted to remain here in active surveillance.
I don't think there's anybody on the screen in your particular circumstance with the high volume 4, and you've got 3 heavy hitters saying that perhaps you need to do something. So
Gotcha.
I wish it was different, but I think I'm kind of sure that with the, I guess it'd be unfavorable intermediate, as Michael says.
Right.
Wish it was something different.
No problem.
Okay.
I appreciate the feedback.
Okay, Mark. Well, keep
Keep
us
us
posted.
informed, man.
Yeah, keep us informed. Bounce back. Say
come
hi,
back.
tell us what's going on.
Yeah, good luck to you, man.
Hey, Mark.
Hey, Mark. Hey, Mark.
Come back, Mark. Go ahead,
Is it confined to one side, or is it confined to one side or the other?
Yes.
Because when I was meeting with Dr. Carroll today, you know, he was talking about potential treatment, and a lot of people, we talked about this, and I can talk more about it later, about not liking focal treatment that much. And I had talked to him about that, and he said, well, you know, you could say the same thing about radiation in terms of not knowing whether or not you've got it all, and it's all kind of a crapshoot. So if it's all on one side, you could consider some focal treatment as well, a hemispheric or a hemi HEMI ablation or whatever they call it. So that might be something to think about too in terms of having to move on to treatment. I think that Ray and I, we're both intermediate, but we're on the favorable side still. When you get over that 50%, it seems like it's a real marker where they start to say, hey, you're going to have to do something. And I think a lot of us try to say, okay, how long can we stay on 3-4 favorable before you get over that hill? And like we say, we all don't want to be on the other side of that damn hill that you're on.
No, I appreciate it. And just an FYI, Epstein said that he was not a big fan of focal therapy, that in his experience, it comes back more often than you would like and are often worse and harder to treat subsequently. Whereas when I spoke with Dr. Chang, he told me that if it ever did resurface in any other part, we could repeat this HDR brachytherapy treatment at that time with no ifs, ands, or buts. He then went on to say that he recommended that in addition to treating the actual lesion, the tumor that's been identified, he would like to treat the rest of the gland at the same time with a lower dose of radiation, just as kind of a prophylactic type of approach. And his justification for it was, if it ever does come back, he said the 1+1, meaning the treatment that I would get now on just the tumor, versus in addition to what I would get if it ever came back, the 1+1 would be like 3, and it would be more radiation over that combined period of time than if he did the prophylactic treatment at a lower rate to the rest of the gland. I'm not 100% sure I'm ready to agree to that, because radiation is still radiation. And, you know, I might just say to myself, no, let's just treat what we know is there now, and then we'll wait and see what happens in a few years. Not only because he said it could be treated again with the same sort of protocol, but also because there could be new ones that are developed in the next few years that might be even more effective and, less toxic. But he was pretty compelling in his explanation about the limited side effects that he's had with his patients. And he was
saying, so he was saying brachy on one side and light on the other?
No, as part of this HDR
Gentlemen, we
brachytherapy.
really don't want to go into this therapy stuff, okay? If that's not what we do here. So, Mark, I don't mean to cut you short, but if you want to have an offline conversation about the different therapies that you're discussing and what they do, that's fine. But this only gets other people more confused because they're not crossing that line. They're not going there. And if and when they have to go there, we hope never, who knows what's out there. And, you put out some good names, Dr. Chang, of course, Schultz, we can send them in that direction. But I don't mean to cut you short, but we really don't want to keep talking about these different therapies. Okay.
Gary, could I ask Mark what his PSA has been doing over the last couple of months?
It's been stable for the last year or two, right around 9.
Okay. All right. Okay. We've got some other people. Dan, actually, you're up. Have you got something else you want to discuss?
Dan from San Diego.
Yep. You're the guy.
No, I don't know. I think it's mostly y'all come out tonight.
Okay. All righty. Hey, Jerry, you still with us? Yeah, you are.
Yep. I'm still here.
What
How you guys doing? Well, listen, I just wanted to give you an update. I started with Rick. We talked a couple weeks ago, and I just want to give my background. And I think it's a very interesting conversation I had, and I think you guys want to hear this. I went to Penn, and I got an MRI about a year ago, and then I got a biopsy. Long story short, I had a 3+4. The guy, my PSA was a 3 or 4, and then I came back the following year, and I came back for an MRI and a biopsy. That was just for this past July or September, something like that. Unfortunately, the doctor said, well, we don't need an MRI. And I came to the group, and the group said to me, get rid of your doctor. If he's going to not do an MRI and only wants to do a biopsy, it wasn't the right thing to do. I sent him an email, asked him why, and I really didn't like his answer. And so coming to the group, somebody had mentioned a Dr. Poonen in Miami. I moved to Florida from Philadelphia back in January. I went to see Dr. Poonen. He could not understand why I didn't get an MRI in Philadelphia. And I got an MRI and also got the biopsy. So I was a 3+4 in Philadelphia. I got the results about 2 weeks ago. He comes in the room. He says to me, listen, you don't have a 3+4. It was a 3+3.
Good.
And that's a little bit frustrating. Nothing grew. In fact, it wasn't as bad as you thought it was. Your PSA being 10.2, it really doesn't mean anything to me. Quite frankly, he said to me, come back in 6 months, do a PSI, and in a year, do an MRI. One thing he did say to me, he goes, and the reality of it is, if you're in a 3+3, he said the same thing you guys said tonight. Chances are, not 100%, you're going to be good for a long time. And the fact that you're getting it checked is better than most of the population. And
there you go, Jerry.
What's that?
There you go.
Yeah.
Good advice.
And I walked around for a year, and Rick knows this. I was very frustrated. Had I not joined this group, I don't know. I knew I should not have gone back to him, but I'm figuring he's Penn, and and he told me don't worry about the MRI. But in fact, everything was screwed up coming from Penn. And the doctor looked at me. He goes, this is bad. No MRI, and you never had a 3+4. Now, I'm listening to you guys, and I'm thinking maybe I should go talk to Dr. Epstein, or maybe I should just leave it alone. I don't know. What do you guys think?
Well, we're big advocates of second opinion, so we never have I would, for your own peace of mind, because here again, you're saying, should I, shouldn't I? For $300 or $400, or if the insurance covers it, why don't you have the best in the business? We sent you to Poonen. We like that guy. He's a great guy.
Yeah.
We got a lot of faith in him. But for peace of mind, my bet is you send it to Epstein. Just let him confirm what Dr. Poonen told you, and you'll feel that much better.
That's what I'm going to do. So I'm going to take the two biopsies and I'll send it to him, and there we go. So that's what I wanted to report back. It was a good.
That's
so
great
far,
news.
good conclusion.
That's definitely great news. We're happy for you, and you know, come back, of course. Engage in conversation and let us know. Let us know how it turns out. But you can never go wrong with a second opinion, especially from him. Michael, you wanted to ask something?
I just wanted to comment. He's a guy just like me, and I'm so thankful for this group, y'all.
We're happy to be here. We're happy to support everyone, exchange information, exchange knowledge. That's what it's all about. All right. Well, that's a really good. That's a good note.
Right, so thank you to the group, and thank you to Rick. Right, thank you. Okay.
So I'll just say it cost us a lot of money to get Poonen to tell you that. You know that, don't you?
I know that. He told me don't tell too many people about me. No, he's a good guy. He's a good guy.
Seriously, he's a very good guy. And one of the things we really pride ourselves in here is that we do tend to send you to very good people. And it's not just because we think they're good people, it's because we've sent other people to them and they've come back and they've said what you're saying. And we smell out the charlatans pretty quickly. And the guy you saw at Penn, even though he's part of the group, he wasn't really in the main practice, and it just didn't smell right. So really glad. Hope you've got the peace of mind. I absolutely agree with Gary. I'd get a second opinion from Epstein. If it came back at something different to 3+3, I can assure you Dr. Poonen would respect it. And then you got something to talk about. And if it comes back at 3+3, you're going to feel way better. So that's the bottom line. And the only thing I can say to you is remember us at the end of the year when we come along and ask you to put your hands in your pocket, because this is why we're here.
Here we go. That's the preamble. There you go. It's coming. It's coming, everybody. All right. Ignacio, you still with us, buddy? I can't see him. Is he here?
I don't see Ignacio.
No, he drops off early, Ignacio.
We're running a little late. Let's try to get to somebody else. Jim F. in Northern Cal. You with us?
Yeah, I sure am.
Okay.
So anyway, I think a lot of you have heard the name Peter Carroll here at UCSF, and he's one of the great worldwide proponents of active surveillance, and I was able to go see him today. Quick reminder, I'm a 3-4 with a very low percent of 5 and 10% of the 4. My Decipher was a little higher than I'd like, 0.62, so just out of the intermediate range, just into there. MRI, PIRADS 2 on the MRI. I did have a PET scan that found 3 little lesions, and they're all on the right side. So I went in there for a second opinion. He had all the information except for the PET scan itself. And I was a little surprised. I thought he was going to be a little more of a proponent of active surveillance, and he certainly was. In the grand scheme of things, but he talked a lot about treatment. Of course, he is a surgeon. We talked a little bit about what I think is the biggest issue for us, and that is, when do you have to make that jump? How long can you go on active surveillance before they say, okay, hey, you're getting a little bit too close to the bone here, no pun intended, and you're going to need to make that loop over. And he talked a bit about it, and one of the things he said is that, well, obviously you just keep an eye on it, and, duh. But he also said, you do biopsies once a year. And I said, well, you think doing a biopsy that often is okay? And he said, oh, yeah, absolutely. He goes, there's a lot of people that are starting to feel uncomfortable with biopsies, and although they aren't pleasant at all, no uncertain terms about it. He doesn't believe there's anything like needle trace tracks or anything like that. He hasn't seen anything to do with that. So he believes that the constant MRI, even though I was a PIRADS 2, he said you can still see if there's changes in it. And biopsies, probably annual is the way that you would monitor it to see if you get up and above that borderline to where you're starting to get unfavorable, and when the 4 starts to take over, and then maybe you need to do something. He recommended, of course, a lot of lifestyle changes in terms of plant-based diets and exercise and things like that. But he was basically saying, come over to UCSF, which I plan on doing next year when I turn 65 and I'm Medicare. And we'll do an MRI once a year along with a biopsy once a year, and we'll keep an eye on it until we can, until you feel that you can't get over that lump anymore. He did talk a bit about, I said, the thing I'm worried about is if I delay treatment, does that mean when I do treatment, I'm going to have a worse performance, quality of life issue, especially around erectile dysfunction? And he said, no. He said, if it does grow slow enough, even at a 3-4 rate, that when you decide to do something, even if it's 2 or 3 years down the line, we'll probably end up doing the same thing we would have done anyway, and your results aren't going to get worse. So it's not like you're sitting there going, if you would have it taken out or irradiated today, you would have maintained your erectile function. But if you wait 3 years, then you're not going to be able to. He said, I said, I'm not, I know the morbidity isn't different, but I'm worried about the function, quality of life differences. And he said, you probably wouldn't see it. And at this juncture, being 3-4 completely in the capsule, not bumping along the edges where we can feel it and things, your risk of metastasis is super, super low. So, I wouldn't be sitting here worrying that if you wait a while, that you're going to be risking metastasis or anything like that. And that's probably just the way that we should watch it if that's the way you want to go. So I thought I'd just give you guys a little bit of an update of what he said.
So Jim,
I appreciate that.
I don't object with anything that he has said. I think the annual biopsies, if you've got 1, 3, 4, that's all you've got is 1, 3, 4.
I have, I think 5 out of the 12. Some were double samples, so 3 out of the 12 with 5 cores that they measured, 3, 4, 5, and 10%.
So 5 cores at 3 plus 4.
I think it was 5 cores out of the 12 pairs, so the 24 came back. 1 was 3, 3, and 4 were 3, 4 with a 5, 5, 5, and a 10%. I am saying I've got those in Zhao's hand right now for a reread.
So you might go. I've got 1 core, 3, 4, and 2 cores of 3 of 6s. So I get an annual MRI and quarterly PSAs, but I'm not getting an annual biopsy. I'm probably going to go 3 to 5 years. As long as the MRI and everything is steady. So you might talk to him about whether you can push back on a biopsy if everything else is steady.
Yeah, I was thinking the same thing. On your PIRADS, was it really visible on your MRI?
No.
Okay, because mine wasn't either. And some people say, oh, well, that, MRI can be 5, 10% false negative. But I'm saying, is it because you couldn't see it because it's not dense enough? Or, is some disease can just happen to be the same density as the surrounding tissue? And he didn't seem to be concerned about that.
Yeah, my guy has taken all of those MRIs and looking across the time and everything else. Like I said, my guy is definitely, the trend is your friend. The trend is trend is flat. You just keep on going. So, and the reason why he would be recommending some biopsies, maybe more so in my case, is because of being on the younger side, and I'm now 67. He said if I was older, he wouldn't be recommending biopsies as frequently. So, and he's pushing 3 to 5 years.
Yeah,
that's good. I'm 6. I'm 64.
Correct me if I'm wrong, but have we heard anybody suggesting a biopsy every year?
Oh yeah, no. Some of the guys are definitely getting biopsies every year, but a lot of other guys are getting 3 to 5.
We also,
my Kaiser guys, they wanted me to get a biopsy 7 months, I think it was 7-8 months after my first one, and I said no.
Yeah, but that's a confirmatory. That's part of some guidelines for some of the organizations. Once you've done that, I mean, I've never heard of yearly biopsies either.
I mean, that's old school, supposedly.
Yeah. You're right, Phil. Back in the day, it was the annual biopsy. Now, of course, they're preaching an annual MRI to take a look and see the trend. Like you says, the trend is your friend. Like you said, Dr. Carroll, I guess, it's uncomfortable. It's certainly tolerable, but there's also some science saying that, you really don't want to go in there and keep poking every year either. So unless it's absolutely necessary, that would be if they saw something, I believe, in an MRI, something different. So I was
surprised too.
And Jim, you mentioned the concern about erectile dysfunction. I've read this. I've never heard anybody say it, but I've read that a potential complication of biopsy is erectile dysfunction.
Good. Okay, that's good. That's good to think as well. I was a little surprised, as I thought Carol was sort of cutting edge and such a proponent of active surveillance. So what I was really looking for was somebody to say, Jim, you're low favorable. I'm supporting you. I did not get the feel that I thought I was going to get. My wife and my wife went with me even, and we looked at each other going, that's not what we expected. We expected somebody to say, yes, you can, even if you can get 3 to 5 more years out of your full function, we'll be on top of it. Go for it. He was not as big a proponent as I imagined.
You got to get Rick to send him a check.
Michael, you got your hand up. What's up?
Well, I was going to say, I think I heard him saying, correct me if I'm wrong, that some of those biopsies were taken from an area where they did not see a lesion, and MRI invisible lesions, according to Dr. Klotz, are more favorable. That's a better thing to happen. It's no guarantee. And I think I'm hearing that Dr. Carroll was leaving the decision in your lap. He wasn't pushing you so much one way or the other. And, that's one of the things this group's supposed to do, is give you information, and then you choose your direction. Correct me if I'm wrong there.
I think that's a good point.
Certainly try to disseminate as much information as input from everybody that's on the screen and everybody that visits us, whether every week or as much as they can. But I kind of go with Phil on this. I mean, I haven't heard biopsy every year.
Long time.
I don't think there's you get the first biopsy, you get a confirmatory biopsy, perhaps the next year, right? 12, 18 months later. And then basically it's MRI. And then the protocols, I thought, at the Center of Excellences were anywhere from 3 to 5 for another biopsy, as long as you have an annual MRI and it comes up with the same trend, like you says.
Yeah, but you're missing something. Guys, you're missing something. And I absolutely agree with Michael. I think you're right if we're talking about a 3+3. I think you're absolutely right if we're talking about a 3+3. When we're talking about men who have 3+4, low intermediate or whatever, I forget the terminology. It's a different ball game, and I think we've got to take that into account. And I think the reason why Dr. Carroll is more conservative is because we've got a 3+4, and he considers that the 4 is something a little different, and it might not even be 3+4 like Hughes. We don't know. We've got to look at that. So, Ray, you have your hand up.
You're on mute.
Just point out too that he's got a decipher of a point. He's got a 0.6 decipher too. That could be what's pushing it.
Yeah.
Perhaps
He
with all things
recommended that
considered,
He also recommended that I get the, what's it called, AnCan, the other genomic marker.
I don't know that I'm familiar
It's
with
our
AnCan.
Artera AI. Artera AI.
Yeah, Atari AI, exactly.
Rick, your point is well taken, but do we not believe that PSA and MRI is a reasonable way to follow, low risk or low intermediate risk disease, and that we have to do something invasive every year? That's a kind of depressing thought.
Yeah, but I think low risk, yes. Low intermediate risk, no. I think low intermediate risk has to be considered in a different light. And that's why this is such a great group, because we have a bunch of 3+4 guys in here, and we've got somebody like a Mark Mizurek. Would you let a Mark Mizurek go for 3 years without doing a biopsy? Probably not.
no.
But you've got other guys who might be like you, who just have 5% of 4 and what have you. You'd let him go, but the 3+4 requires, a little more nuance.
I will say that me personally, just my opinion is, I have a lower tolerance for repeating biopsies than some of you guys do, because I think that's the place you're going to get your definite answer. But again, me personally, I have a high tolerance for pain, and no, they aren't comfortable, but I'm not terribly bothered by having one either, as long as they'll do it perineal and not transrectal.
And again, I think it's an individual case, as some of the things they pointed out, the decipher score, and you have to consider Peter Carroll, who he is, what he's done. He's a good guy. Might have to getting the Arteria AI is not a bad idea, and then perhaps get another biopsy, get another second opinion, and it won't be, perhaps things will change. Maybe that's something you can hope for, something you want to go with. All right.
So
Go ahead.
Is Joel still around? He was wanting some time.
Sure.
Joel?
Can you, yes.
Yeah. What you got, Joel?
All right. Okay, great. Yes, I'll be real quick. So over the course of the last 2 years, I've had my PSA test done every 3 or 4 months, and they, except for one time, which was 6 months ago, my scores have always stayed between 6 and 8. 6 and 8. So again, 6 months ago, my PSA score at that time bumped up higher than 8. It came back at 8.9. And I was very concerned, thinking, how come it jumped up 1.3 points? And I just couldn't understand, and over the course of the last 2 years, my PSA score has gone back and forth between 6 and 8. So I, on one of these calls here about a month ago, I don't know why I didn't hear it as clear. And tonight I've heard so much about how it's just important to try to have your PSA done at the same lab. So I thought to myself, well, my gosh, that PSA test that I had 6 months ago, I did not have that done at the same lab where I have had my PSA test done over the course of the last 2 years. So last month, I made it a point to go back to the lab where I've had my PSA scores done, and sure enough, it dropped below 8. So I have to thank this group because I would not have known why the hell that PSA score went up so high unless I had heard it here. That it's just a good plan. It's just a good step to go ahead and try as much as you can to have that to have the same lab do your PSA scores as much as you can. So that's all I wanted to share.
Well, that's Joel. That's a great story, and you can imagine there's some doctors that would act on that higher reading when in fact it's to do with labs.
Yes.
And
yes.
And don't wait around for them to come up with that answer.
Tell you a quick story, Joel. When I was had a local urologist, a PCP guy, regular PCB guy, and back in the day, the magic number was 4. It's kind of like 2 now, but the magic number was 4. And when it went over 4, I went to 4 point something. He says, you got to go see the urologist. He never said to me, it never forewarned me if I had any kind of sexual relations before that, or did I go for a 50-mile bike ride like you does? He didn't ask me any questions. He just looked at that number and said, "Hoop, you got to go see a urologist." So this is what we try to do here. We try to enlighten, we engage, try to educate, and mostly support. Help people get through the journey because we're all on this journey. All in different places, different ages, different situations, different locations. And that's what we try to do. But that's a good story. And that's something we'll most probably repeat down the road somewhere. So I'm glad that you shared that with us. Jerry, what do you got?
I just want to say something. Dr. Poonen, he saw that I was a 10.2 PSA. And he said to me, I'm not concerned about a 10.8, a 10.2 at all.
How old are you, Jerry?
66.
Okay.
That's what he said. He got, I don't know.
Jerry, a lot of doctors don't look at the individual ones. They're looking at the doubling over time.
Well, I was a 5 and went to 10. But he goes.
Over what time period?
Like 3 years.
You're right. Okay. So I don't know that's why I'm saying some of them they look at over time. They're not so concerned about the actual one. So
and some of them don't put all their eggs in the PSA basket. The more you read the more you read the active surveiller, the more you read the stuff that Rick's puts across. It's a standard. I mean, it's like where everybody starts, but it's not the gold. It's not the golden goose.
I asked him, I said, I'm just curious. So let's say it went to 15. He goes, when you come back, if it goes to 15, he goes, we're not rushing to do anything here. He goes, you're in surveillance. He goes, and that to me is the number I'm least concerned about. I want to see, that's what he said to me. So,
yeah. Well, time is all on our side. Everybody, even like Mark, he's got time to make these decisions.
Absolutely.
3 months, 6 months, most likely 9 months, perhaps even a year is not going to make a hell of a lot of difference. It's just the way the disease goes.
Yeah, that's true.
All right, gentlemen. I know we had some latecomers. Robert C. I'm sorry we didn't get to you. You came in late. Did you need some time? Is there something you wanted to discuss? Do you want to come back next week?
I'll be back next week and I'll share.
Okay, well, I'll put you on the next page here, buddy. So I'll call on you next week, all right?
Mark,
I know you
good luck, Mark.
got to try to make it on time to get in the roll call, all right?
Yes, boss.
Ray
So
from Santa
Gary
Monica. Ray from Santa Monica, you still around?
He's gone.
Yeah, he came in late. So, all right. I think that's it, gentlemen. Make it a wrap. It's almost 10 o'clock, so we ran
Thank
a little
you.
bit over. So
Thank you.
everybody
Hey,
have a good.
before we jump off, Mark, are you still there? Mark?
He's on mute.
Yes.
Yeah, there he is.
Yeah. So, Mark, I wanted to come
Hang on,
back
sir.
to something for you, and that's on
I'm
focal
gonna mute you for
therapy.
a second.
Okay.
Yep.
And what I was going to share is when I first went over to MD Anderson, I asked about focal therapy, and my doctor, he didn't like the idea. And so I've been with him now, I guess, about 5 years. And the topic of focal came up, and I said, well, you're not a proponent of focal. And he said, well, no, he said, let's hang on to that. I said, well, when we first came, you said you weren't a proponent. And he said, I'm not a proponent of focal early on in somebody after an early diagnosis. He said, what they found is people that, get diagnosed with something, maybe, low risk in my case, or something, a 3+3 or, or whatever. And they jump off and they go in and they do focal therapy. And then right away, within 2 years, they sit there and say, oh, well, it came back. Well, he is a proponent that you need to have more time to determine where the problem area is over time, and then be able to use focal. So it was interesting that he says that focal does have a point, but don't do it too quickly after a diagnosis. You've been around for a long time, I think, Mark, and you've been diagnosed here for a long time. So, there may be something for focal for you.
I appreciate that. Thank you.
Okay. That's what I had.
All righty. All right. Good night, gentlemen. We sticking around for a minute?
Sure, we could stick around.